Dr. Andrea, did I pronounce that right? Andrea Graham here for our first one. She's going to be presenting on designing digital mental health interventions to optimize engagement and implementation. She is an amazing assistant professor at Northwestern University's Feinberg School of Medicine and the Center for Behavioral Intervention Technologies. I got to know her last year a little bit through the Society of Behavioral Medicine, where she received the new investigator, early stage investigator career award. So she is definitely a superstar. Her program of research is focusing on the design, optimization, and implementation of, again, evidence-based digital mental and behavioral health interventions. And she uses really innovative work on human-centered and user-centered design methods and engagement to design implementation plans to support integration of digital interventions into practice. So we are thrilled to have her here.
Thank you. I really appreciate this opportunity and excited to present today. Hopefully you're seeing the slides again. We practice, but you never know with all of our technology world. Thumbs up is great. So I'm Andrea Graham. Thank you so much for that introduction, Rachel. I appreciate it. And just, look forward to presenting today. So why I love presenting on digital interventions and doing work in this area is that really the disruptive innovation, meaning the game-changing component of why we do digital work, is extending treatment beyond in-person sessions into the fabric of people's lives. But if these tools are not engaging, people will stop using them. And so we need to make them engaging in order to have clinical impact. And this is sort of the take-home crux of the work that we really do. It's quite simple. And yet engagement is a problem. And so when digital interventions have moved from research settings to real-world settings, implementation has frequently failed, where we see low rates of use and retention among patients and failed integration within their systems of care. And part of why this chasm exists is that interventions are often not designed for the users and the context in which they'll be implemented. And the disconnect is that these tools need to be designed to fit into the fabric of people's lives, where we really need to think about contextually relevant care that's better matched to patients' needs through personalization and precision, and better matched to clinicians' workflows through, for example, pragmatic designs. And this is where design can help. So my goal today is to talk about designing interventions that both meet users' needs and that can be integrated into workflows. I personally focus primarily in healthcare settings, but this work can, and these methodologies very much apply beyond healthcare as well. And so let's start with talking about mental health apps. And so one of the things that we've seen people do by and large is simply translate a face-to-face treatment to a digital format. And that's basically been problematic from an engagement perspective. And here's why. Where typically these tools have been designed where they rely heavily on psychoeducation, so a lot of reading. They require about 30 to 45 minutes of use per week, typically for 6 or more weeks. And in this kind of context, engagement can be really challenging. So now let's think about how people actually use apps in their day-to-day lives. So this is my drive between my home and work. And I'm home today, but I am going, we are going back. So we're back to hybrid and moving back in person. And essentially, for those that are familiar with Chicago, there's 2 different ways that you could mainly take. I could take the highway, or I could take the much more beautiful Lakeshore Drive. And each morning I open up Google Maps and I figure which route is going to be fastest. And then I close Google Maps. And then at the end of the day, I get to the parking lot, I open up Google Maps, I figure out which route's going to be faster, and I close Google Maps. That's it. And so typically we're using apps for single purposes in short bursts of time, sometimes frequently throughout the day, with a much greater focus on action over psychoeducation. And what that boils down to mean is that altogether, the user experience in these tools matters. And so this is a theoretical model that colleagues and I proposed as, for those that are familiar with the RDoC criteria through National Institute of Mental Health, where we think about mechanisms to target. And we really strongly believe and have done work to support that actually targeting engagement and sort of the, not just how many clicks people have, but really the subjective experience that people have in these tools, that a well-designed app that leads to high engagement is actually one mechanism by which we can see changes in clinical outcomes. Put a different way, we can have the most potent tool that if no one uses, it doesn't matter. And so when we think about engagement, we use the term subjective. Other groups, there's definitely other ways to phrase that, but for ease of comparison, we think about it as, are these tools useful, right? Is this a value to me in my life? And then is it usable? Is it easy for me to navigate through it? Do I require a lot of clicks, or is it very clear how to sort of swipe, for example, through an app? And then how satisfying is it? So does it create a positive user experience? And one of the things we actually like to talk about is thinking about clinically meaningful use. And so not just having people use a tool for the sake of using it, but actually using it in ways that are clinically meaningful. And then, of course, just like in therapy, how do we get people then out of the app once they've used it in the ways that are going to make them successful? And so this is where the human-centered design, or sometimes phrased user-centered design or design thinking, this is where it can help. And this is a model that one way of approaching the process. Typically, the stages are relatively similar, but sometimes described through different models, where basically it begins with the investigate phase. And I will share later how basically embracing human-centered design has been my personal disruptive innovation of my career at this point, is really sort of engaging with the people who are going to be using these tools and those that are impacted by them. And so human-centered design, and actually I should amend this model to show that basically it centralizes all of our design questions around who is going to be working with these tools and the types of people that might be impacted by them. And so we begin with the investigate phase, where if you were like me as a licensed clinical psychologist, early on, I thought, like, I already know what the needs are of these patients. I've been working in these clinical populations for a while. And the answer, as I'll show you some examples, is no, we need to really go back to the drawing board and really understand the goals, needs, and preferences of target users and relevant partners in this work. And then from there, we ideate. And so ideate's where we're really brainstorming all kinds of concepts and design ideas for a product design. And then my personal favorite is prototyping, where we're coming up with working iterative versions of a product design. Anything can be a prototype. So Post-it notes on a wall. There's a famous paper of using a pizza box. I don't know about famous, but from a long time ago around using a pizza box, for example, as a briefcase, like to get a sense of the look and feel and how it would feel carrying that. So lots of things can be prototyped. The goal is that you're then evaluating those iteratively with relevant stakeholders who would use that, and circling back so that your prototypes are consistently evolving into more fine-grained version. So early on, you might be doing this on a piece of paper, sketching it out. Over time, you're making it sort of look more and more refined for what would actually get built. And then stage 5 is refine and develop. And it's not here until you really then start spending money on software development. And we're going to talk about why sort of waiting till all the way to here is really important. And then finally is the validate stage, where many of us maybe on this call in academic medical centers are most comfortable, where it's really where you're then testing this in practice. We sometimes call this in the wild, but really thinking about clinical trials or pilot trials, trying to validate the tool. But what we know is that anytime you put technology in front of people, it's not going to go quite as planned, and you're going to get feedback. And in fact, it could be because the technology changes over time, or users are actually changing over time, or context. And so you're going to then potentially even restart this whole design process, where you're gathering continued feedback and iterating on prototypes over time, on your design over time. So why human-centered design? Well, there's great advantage to upfront effort. So as I just explained, we can do, I didn't explain this part, but I'll skip around my bullets. So basically it really does enable rapid learning through this process. So even though it seems like this, oh my God, this many stage cycle could take a while, actually there's numerous design methods and techniques that can be applied. And there's sort of a whole bevy of things where it's not like it's a choose your own adventure, right? You sort of think about which methods might fit best for the kinds of questions you're trying to answer. And most of these methods can be implemented relatively quickly. And for those of us on the call, again, working in academic medical centers, I've been able to do a lot of rapid learning in ways that is IRB approved and doesn't hold me back from being able to do this iteratively and quickly. And I'll refer folks to there's a review paper reference at the bottom of the screen. It is in the eating disorder field where I particularly work, but basically it summarizes lots of methods that could be applied in general within human-centered design work. But also importantly, and this is what I started to talk about just before, is that a lot of why upfront efforts are really important is because it saves money and rework later. So we know that many of these problems with technology are avoidable if we're given adequate attention. And this is from, this is a very dated reference, meaning like these principles still very much apply. And so if we then think about, really spending upfront efforts on design, we're going to then save the bulk of our money, where when we think about grant dollars and you don't have a ton to do software development, it's really important to know what you want to build before you build it. So this is where I'm going to move into the first portion of the talk around designing interventions to meet users' needs. Many of us in the implementation science world are very used to mind the gap and sort of the cliche of that concept. But essentially, I'm going to share a little bit about my work where I've been focusing on a clinical gap for people with binge eating and who have obesity, who are interested in both reducing their binge eating and managing their weight. And essentially, this has been a big portion of my program of research. We're thinking about an intervention that would be more precise for this population, but also efficient and scalable. And so what we've learned is that people with binge eating, for example, often want to lose weight, and our treatments don't address that. And they're going to then drop out of treatment when they learn that they can only lose weight once the binge eating is resolved. And so how do we think about a more efficient and combined approach? And that's where I've designed Food Steps with support of a career development award from the NIDDK. And the portion of this talk is not to then have everyone be convinced about a theoretical model for how to treat binge eating, but to use it as an exemplar for how I've applied these methods and thinking sort of more creatively about how we intervene with a digital tool. And so my goal was to combine theoretical constructs for binge eating and to change weight into one app, but think about how to do that in an efficient way. And so as I've shared, this has been my really sort of big picture change, is how do we think about what I think needs to go into an intervention doesn't necessarily align with how people use their phones or the kinds of things that they want from a tool, and really embracing sort of that notion and the design principles. So what we've done is designed the Food Steps intervention, and we're literally wrapping up the pilot trial at the moment. And I just want to point out, we've had over 150 people do design activities for a pilot trial of 81, meaning I really invested a lot of time and effort in design early on and consistently throughout the pilot trial, so that we can consistently learn the kinds of iterations and changes that we need to build into this program. And the initial question that I asked people was, how do binge eating and weight impact your day-to-day life? And I sort of share, and particularly for clinical researchers, when I first received my K, I thought I would just go straight into prototyping. I had just gotten licensed. I thought I've been working clinically with patients for a long time. I sort of know what they need. And my mentor in the human computer interaction field, HCI, sort of my design mentor, he said, no. And I said, yeah, no, I really know what we're going to build. And he said, no, you need to go back to the drawing board and you need to start with the investigate phase. And sort of the behind the curtains answer is that I actually hadn't even planned to do that as part of my K award. And it was exponentially invaluable into the type of learnings that we really came about with, where what I started with is really revisiting the question of how do binge eating and weight impact your day-to-day life. And my sort of favorite implication of this is sort of which is people present to treatment with really wide variation in past experiences with treatments and past interests and needs. And I was really reminded through this needs assessment work that in this context, when it comes to eating and managing weight, behavior change really isn't new to these folks, where 100% of the people I engaged with endorsed past attempts to lose weight, and 91 endorsed past attempts to stop binge eating. Now, I have no clue if they were in evidence-based programs, if this was on their own. It doesn't matter. What it was reminding me of is I'm not designing a tool that people hadn't conceptualized before in some way, that this was really an approach where people were not coming in naive, and I needed to think about how to cater to that. And to the first bullet around the wide variation, how do we think about something that with a digital tool. In clinical practice, you could talk to people and personalize. In a digital tool, you have to be a lot more thoughtful about how to personalize in a one-stop shop to make it so that people can meet their needs. So one of the ways I started to conceptualize this, and I really credit Sean Munson at University of Washington, who's wonderful in helping me think about user-directed behavior change. And what we did is a prototyping proof of concept project where we asked people, what do you want to work on? And we gave 25 people choices of things that they could pick. And we said, go do it for a week and report back to us over the course of the week how it went. And during that week, we gave no feedback. Like literally, we just sort of said the topic. We didn't even give psychoeducation. We just sort of tried to figure out how would people make sense of this on their own. And what happened was pretty awesome, where the vast majority said that it went as planned or somewhat as planned. I think a word got cut off. That it went as planned or somewhat as planned in that approach. Did it help? The vast majority have said yes. Will you keep it going? The vast majority said yes. And finally, did it work? We didn't expect to see changes, but we did technically ask people, what was your weight at the start? What was your weight at the end of the week? Just to get a sense of being in that process of the self-monitoring. And we saw that there was average within subjects reductions in weight and binge eating, surprisingly. And so really the design implication around this was thinking about offering choice and selecting skills to practice, where we could think about guided customization. So not everyone said it went smoothly, right? And again, we gave them no feedback over the course of the week. So how do we think about actually allowing for choice, but within maybe some swim lanes, right? Within a defined array of credible options, and to offer support in problem solving. So over the course of the week, when people said it didn't quite go as planned, it really reminded me of the importance of, and I do a lot of work in the area of coaching for digital interventions, as I'll show you soon, and sort of the role of offering support, the importance of positivity and reinforcement, and thinking about how we incorporate these kinds of principles into the food steps. So that's where we went from design to development. And food steps is quite simple. We're basically at the start of the week, we do a symptom assessment. We provide very, very brief psychoeducation. I love to tell the story that we did a field trial with 4 people before really rolling this out, where they used the app for 4 weeks. And on day 1, I basically had enough feedback to rebuild the whole app, where I wrote all this lovely content and it was very long. And they immediately said, this is way too much to read. And so I chopped it to truly 3 app pages. So like this is considered 1 page. It's like 4 sentences. Really brief, sort of opposite of what you would normally ever want to do as a psychologist, and people loved it. Like I consistently get feedback, like the amount of reading is just really excellent. Okay, and that's a good example where like really meeting people's needs. And then the crux of basically the tool is helping people set goals and track their progress. A colleague once phrased it that I basically created a goal setting app, and I was quite okay with that. Where basically people are empowered to choose a goal that they want to set within a defined array of topic areas, and then they track their progress over the course of the week. And then we have an eating log as well. Over the course of the trial, I like to also share, I mentioned that design doesn't necessarily end once you roll out. I realized that I had sort of conceptually wanted people to practice past stuff over the course of future weeks, but I never actually built a feature to sort of model that for people. And so during the trial, we actually added in a feature where people could indicate if they wanted to continue a prior goal also, and we added that in. And we're now, as part of Food Steps 2.0, we're thinking about more ways to even continue to build out that feature. It was one that people really liked, which was exciting. So how it's going, this is preliminary data. As I mentioned, the trial is wrapping up, but we're still underway, so we haven't analyzed all the data. But I think as a real testament to the design work that we did, we've seen that usage is really high. So users are completing 80% of the program on average, and adherence is high, where people are selecting a target and completing their assessments on 94% of sessions scheduled, completed. And keep in mind, my assessment is 2 items. And I think that's important, right? I was sort of like, what is the bare bone amount of information I need? And actually now users have said, can you ask me more questions about like my mood and my motivation? And so we're adding that in, which is exciting that they were saying, I want to be able to tell you and my coach more. And then lastly, though, which is sort of the opposite, and I'm always happy to share this point, I suppose, and is the opposite of where most of us are in the digital world, is that we're a need for greater precision. So essentially we are seeing on average weekly reductions in weight and binge eating, but I would argue it's a suboptimal proportion who are having weekly improvement. And so when I say it's the opposite of most people, often we have some really good outcomes among a really select group of users who stuck with it. Here we're having a high degree of engagement. And to me, that's the perfect spot to be in, right? If you're getting people who can come to this tool, there's always room to clinically improve, in my mind. And that's excitingly that we're having some next food steps. Always have to throw in a pun, but basically, I excitingly have received an R01 where we're doing a micro-randomized trial to actually learn, how do we better personalize this program to people's distinct needs and to build a just-in-time adaptive intervention that can more effectively roll out in a personalized way. So we're trying to learn which of those evidence-based targets, I showed you that I have a theoretical model, and to try to better understand which ones are best for which people, but then also to understand when should targets be delivered, like what would be the right sequence of doing that, and how do we appropriately nudge people to change their behaviors while still embracing this core concept of user-directed behavior change. And for what it's worth, this whole trial was actually driven by both what I was seeing as the clinical supervisor but also from user feedback qualitatively, where I was saying, what more would you want in this program? And people were giving me completely opposite ideas for what they wanted. Some people wanted in a given week me to tell them what to do because they had decision overload, and they just said, give me just assign me something to work on. And some people said, never do that and give me something that you recommend. And I suddenly was I was like, how do I make sense of all this feedback? And it was then like, these are good research questions. And it became a really exciting opportunity to then put that together and to think about a micro-randomized trial where in any given week, they're being assigned or recommended things, and the types of targets are being diversified too. But the broader vision, as I shared, is that I do this work, in the context of then where could this actually, pretend Food Steps is the best app in the world. Where would people actually get access to it? And my goal would be that they could actually, do this in clinical settings where people with binge eating and obesity present for care. And so I have an R03 award also from the DDK, thank you, NIH, where we're trying to then apply this service design method. So using these same principles, but to then designing this as a clinical service for rollout in 3 different settings where people with obesity and binge eating present for care, but where they're actually not typically able to address one or both of these conditions. So in primary care, we know that docs are very commonly screening for weight, rarely ever screening for eating disorders. And so basically that would be, the prime setting. And in fact, both of these 2 subsequent, clinics are then saying like, you got to start with primary care. And so working with 3 of these clinical settings as sort of, typical sites where people present to understand what would be the workflow by actually implementing food steps in these settings. So my first aim is designing what I call service blueprints for like really charting chronologically, like the stage of a person shows up to the clinic, someone checks them into the system, like when in that process would they actually get access to this app? And secondly, to create implementation roadmaps, which is a word I made up, to be honest. Not that the implementation science field needs more buzzwords, but where basically the goal is to then specify what are the implementation strategies and what are the adaptations to the intervention and settings that are needed to implement these blueprints in each setting. So we think about across domains. Do we need something in the EHR? Do we need leadership on board? How is this clinically integrated? What are the technology adaptations? And so really creating a guide for a future, hopefully a hybrid trial. And what have I found so far? So when we think about the referral process, 2 different programs have said Food Steps is ideal for their clinic. They often see this as a great tool for people on the wait list. So probably unsurprising to any clinical practice, both the lifestyle weight management program, the eating disorder program, they're vastly, overloaded. There's a long wait list. But then the groups differed in terms of like whether they would want it blended with their face-to-face services or just separately, like you take this person and then, ship it back to us. the eating disorder program, for example, wondered about, who is this right for? Well, what are the severity stratifications of when we would use a tool like this? So once I have the trial outcomes, that's going to help us do some analyses that can help inform the clinical rollout of a tool. But then from a delivery model perspective, it's been actually quite interesting. You could imagine here, I should have explained that Food Steps also includes coaching with a human support. These are non-licensed clinicians who are typically bachelor's level, who provide support and accountability to people using the program. And within each of these programs, they've been very clear that they actually want the coaching offered externally. So they do not want to be the ones integrating this clinical tool into their system. They just want me to take, sort of the Food Steps group does it, and then we can ship them back. In part because of billing and time constraints that we don't currently have reimbursement capacity for digital tools. So how could this fit into their workflow? My program coaching is primarily by text message, so that doesn't quite match with how clinicians who are doing face-to-face work. But I will say we then have done some market research, and really sort of the big tech companies, they're also doing digital work, in the coaching in-house. So this isn't to say that this would be a model that doesn't fit with sort of the market of how people are offering coaching. We've heard from actually all three groups that they would want routine report backs on patients' progress. And what I love about that is now that to me sort of brings my antenna up for all kinds of how often, and I'll show you on the next slide sort of some mock-ups of that, is to really then design what does that report back look like. And interestingly, because I'll talk about an EHR alert shortly, primary care has said, do not add another EHR alert for me. Do not do anything more in the EHR. That would not be how they would recommend doing it, which is going to be a key point for later. And so similarly, to that point, some of the next steps are where I'm now in the process of mocking up clinician reports, and with the goal of iterating with the clinicians in the clinics on the design, the frequency by which they would want this, the follow-up workflow for when we would, what they would do with this report, sort of you get this, now what? We're looking into potentially including this not as an EHR alert, but as part of a resource list that gets siphoned to people regularly, but also thinking about what additional strategies would be needed to support patient uptake. And then ideally, I'll pilot these referral and delivery processes so that we could sort of see actually what happens once you put it into practice. And so that's really where I'm going to get into the final stage of my talk, which is around designing for implementation, this being an example, but really thinking further about how we integrate interventions into workflows. Take a small pause, but I don't see other questions in the chat, so that's good. But essentially, I really think about workflows, and I think this paper by John Toros last year in World Psychiatry summed it up really nicely in reminding us that workflow considerations remain among the least explored but most needed factors towards facilitating implementation. I think particularly for digital, we have to get this part right, or else we're really dead in the water. Again, if it's not used, our most potent tools have no impact. And so I think a lot about sort of the role of designing for implementation relative to digital tools, where we know in general, integrating new interventions into existing workflows is challenging, period, full stop, not really debatable. But actually, this is especially true for digital because the delivery model differs from in-person or face-to-face services by design, right? That's the whole concept of doing a digital intervention, is it's meant to look different. And so actually then integrating it into workflows where whether it's truly in-person face-to-face or even telehealth, that can look really different. And there's been a gap in knowing how, so the methods and techniques to actually implement digital interventions in healthcare settings. And that's where some colleagues and I proposed a set of tailored implementation strategies specifically for digital mental health interventions for healthcare settings across phases of implementation research. And it's a busy model, but to show sort of what we did is we took known or established implementation strategies in the field in general, and we said specifically, how is that relevant to digital mental health tools? And so I'm going to give a second example of workflow integration using a project and a tool I've been part of known as IntelliCare for depression and anxiety. And so IntelliCare is a suite of apps that's now actually been converted into a single app for people, as I mentioned, with depression and anxiety, that's really focused on those design principles I shared early on around being action-oriented, very brief bursts of time, and then it involves human coaching. And that's been my role as this sort of caricature in the center, is thinking about sort of the role of human support and accountability in ways that are really efficient and low burden as part of the clinical strategy. And so I've been involved in this work for the past few years as part of a series of SBIR awards, which are grants that allow an academic and an industry partner to partner together to think about how we commercialize these tools. And it's been a really fun collaboration. It started with this first award where we were in partnership with the University of Arkansas for Medical Sciences, where this was the first trial where we compared IntelliCare to treatment as usual, evaluating this mental health app platform where it was a series of tools and with primary care patients. And excitingly, the trial was a slam dunk. We over-enrolled. We saw what outcomes that we were hoping to see in terms of the people in the intervention group changed over time relative to the wait list. And then interestingly, although it wasn't a primary aim, we explored what happened to the wait list group when they got the intervention and they then went down in their symptoms, and that the intervention group sustained their changes. Awesome. We had effect sizes that were comparable to face-to-face treatment. That's consistent with what we see for depression and anxiety apps. But we were excited. But to the point about how it's designed, this is a busy slide, but just to show you that this is around engagement and ongoing use. It is not that people just use this for 2 sessions and drop off, which is what we often see, the hockey stick of engagement. People really stay on this app long-term over the course of 8 weeks, which is really exciting. And I like to share some of the work that we did around workflow integration to thinking about sort of understanding where this could go within the clinical practice. And so I'm going to focus on this idea of referral management, where what we did is we thought about several different ways that patients could get access to this tool. Some of those approaches were direct to consumer, some were through clinician referral, and then we had a category called other, which was, if one of the team members did a presentation on the Arkansas campus so that patients learned about it, word of mouth, campus buzz, and a newsletter on campus. That was sort of that other category. And importantly, we're going to talk about the EHR alert and order. And as I mentioned, this is where you spend a lot of money thinking about building software. And so it's really important that we're mindful when we're building software and spending those kinds of resources on how we do it, because it doesn't take much to print out a flyer. And so this was the schematic that we came up with for the workflow integration. It's busy, it doesn't need anyone to read it. The point is that what we did is we had a whole team thinking about this. We had the head of informatics, we had clinical researchers, we had doctors within the care system, a designer, the CEO of the company, all of us putting our heads together to design this workflow for how the alert and order would happen in the EHR. And yet, we all have to know that sometimes interoperability with an EHR can be, as best laid plans go awry, where what we saw is that the yield from the direct-to-consumer approaches were exponentially sort of, that is where the majority of patients into this trial came from. So the yield was over 80% came through from direct-to-consumer strategies. The vast majority of people did not end up coming through for an EHR alert and order, despite sort of all the effort we put into doing it. However, I do not suggest that we throw that out the window, which is to say that actually the rate of conversion in terms of how many people we had sort of tried to reach relative to who came in, if the doctor actually recommended this or engaged, that they were much more likely to convert into this program. Meaning we know that patient-provider relationship is so important. And so we need to then think more creatively about how the intervention is then fit into the workflow to actually, sort of be enabled by the clinician for patient access. And so I share some of the then qualitative feedback that we had from docs around using this EHR order. And basically they phrased it that in practice, the timing of the alert was not optimized to their workflow. And for a series of reasons, but it showed too early at the start of the visit. It then didn't make sense for them to act on it at the appropriate time. Or they weren't referring because they actually thought that was someone else's job, meaning certain clinics already had behavioral health services available. So they thought it was then someone else's role to do it. But they all sort of were very enthusiastic about the service and the value it offered. And they also brought up that actually some of our direct to consumer approaches, by having flyers in the waiting rooms or in the elevators, that actually then help patients spark new conversations with them that they wouldn't have normally had. And so sometimes a multi-strategy approach is then, of course, quite helpful. The other piece that is sort of becoming, I think, one of my also new soapboxes that I haven't figured out yet, but it's sort of really nagging at me, is the idea of penetration of these tools. So the whole concept of digital is that we can increase access to care really broadly, and yet we, I think, are as a field not doing well enough. So in our trial, we had a 13% penetration rate relative to the number of patients who screened positive for depression in the last year in that setting. This was higher than other past trials in primary care, and yet 13% is not good enough, right? Let me keep in mind, this was a clinical trial. That doesn't mean everyone should need to come into it, but we know that rates of depression and anxiety, that we would want to see this rate as much higher. And this, to me, is an important point for optimization. And so in closing, what we've now done is thinking actually more about this idea of how do we then assist with onboarding. And so excitingly, we have a follow-up SBIR award where we're now focusing in a rural healthcare setting. And it's the first time this setting is actually referring to a digital solution, not digital mental health, just digital period. And so we're being really attentive to process. And so this is a rough schematic of we're thinking about sort of that blueprint around who refers them, is there on-site support, what are the processes and stages by which patients can get access to this tool. And we've tried lots of different implementation strategies at this point, where we're training clinicians, we're then distributing educational materials. We actually are consistently revising our blueprint to better match rollout as we're monitoring how this is going. So we have clinician-facing materials, patient-facing materials, and then doing routine monitoring both internally and with our partners to see how we're matching up, where we're using both EHR reports of who gets referred and then our app metrics, and so leveraging technology to then do routine referral monitoring. So with all of this, I'm going to close to say that we have effective digital health interventions, but they are not widely implemented in healthcare systems and beyond. And successful integration requires designing these services to meet the needs of users and to align with their implementation context. And I always like to close with also reminding us that as we think about design, we have to be really attentive to how we design interventions for all people, and that we don't then inadvertently or advertently continue to exacerbate healthcare disparities in equity and access. So this was one paper that colleagues and I put forth around thinking about some of the affordances that digital tools offer that actually could put rural communities at a distinct disadvantage if we're not really mindful of how these tools can be delivered, and if we don't create policy changes to support how these would actually be implemented to actually resolve the key barriers that exist in rural communities where digital tools could actually be quite helpful. And then similarly, a colleague who excitingly just joined Northwestern, Alex Sahigios from CHOP, but we wrote this paper last year around thinking about how do we design interventions more effectively for adolescents for whom their healthcare is often really sort of imbued with the sense of transition and handoffs between, let's say, specialty and regular care, but also between that transition between pediatric and adult care. How do we then think about leveraging technology to better facilitate handoffs, and how do we more appropriately use design to think about handoffs and transitions in care processes? And all of that's to say, sort of what it really speaks to is the need to design for context from the start. And the piece about design work that I've really embraced, to use that term for the third time today, is the need to get things in front of end users early on and to focus on minimally viable products. So often in our academic worlds, we want things to be really perfect and really perfectionistic. And in fact, it's way better to get things in front of people early in really rough sketches, and then roll out with what we think of as a minimally viable product so that we can actively learn like what people need and what more to build. So a perfect example from Food Steps is I wasn't necessarily going to include an eating log because people like Fitbit have spent billions of dollars creating Fitbits and MyFitnessPal. Like, why did I need to spend money on it? And yet, of course, users were very quick to say, and clinically we should have it, but users were quick to say, oh, where do I record my food? And on day one of the program. So we quickly added a box, and I said, like, I'm not sure how I would want it to do a whole eating log. There's a lot of sophistication we can do. So for now, we're doing a text box, and let's just see, do people even use it? Are people writing anything in there? Focus on a minimally viable version of your features so you can get it out there and learn. And from that, it really means iterate, 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 where we need to also embrace that real world research comes with real world challenges and the ability to, of course, adapt and be creative and sort of think about how we iterate. And I actually think that's where design methods provide a really nice approach for which we can continue to learn quickly and make changes. And all that to say is thank you. So you can email me if you have any more questions of resources or things, or find me on Twitter. But also, I'd love to share that our center website, I initiated and we co-direct a Design for Digital Health reading course where we have all of our syllabus and articles online. And then our center is supported by a P50 award where we actually have free consultation if people are interested. Other centers have this too. And we're just grateful to be sort of really putting forth these design resources. So thank you.